Understanding the 5 types of esophageal atresia and tracheoesophageal fistulas is essential because each type presents different diagnostic and surgical challenges. Let's break down what makes each one unique. Type C dominates, accounting for 85% of all cases. This is EA with a distal TEF. The esophagus doesn't connect, but there's a fistula from the trachea down to the stomach. Why does this matter? That distal connection allows air to reach the GI tract, creating the characteristic gaseous distension you'll see on X-ray. It also provides surgeons the best opportunity for successful repair. Type A represents the most challenging variant, isolated EA with no fistula. These babies have a long gap between the esophageal pouches with no connecting anatomy. 8% of cases, but they often require staged surgical approaches because you can't simply connect the ends. Types B and D are uncommon variants, only 1% each. Type B has a proximal fistula, creating significant aspiration risk. Type D has both proximal and distal fistulas, making diagnosis complex and surgery technically demanding. Here's the clinical insight. Type E, the H-type fistula, often escapes initial diagnosis. 5% of cases, but these babies can feed normally at first. They present weeks or months later with recurrent aspiration pneumonia because there's a communication between the trachea and esophagus, but both structures are otherwise intact. The key concept? The anatomy determines everything: your diagnostic approach, surgical timing, and expected outcomes. Type C offers the best prognosis. Type A presents the greatest surgical challenge, and Type E most commonly leads to delayed diagnosis. Recognizing these patterns helps you counsel families appropriately and plan surgical strategies that match the anatomical reality. EA in TEF typically announces itself early, but recognizing the pattern helps you secure the diagnosis quickly and safely. Prenatal clues often provide the first hints. Polyhydranose occurs because the fetus can't swallow amniotic fluid normally. There's nowhere for it to go with esophageal atresia. The small or absent stomach bubble on ultrasound reflects the same problem. These findings should raise your suspicion, but they're not diagnostic by themselves. The classic triad at birth makes the diagnosis clear. Excessive oral secretions and drooling happen because saliva can't reach the stomach. It just pools in that blind upper pouch. Choking with feeding attempts occurs for the same reason, but now you're adding formula or breast milk to an already compromised airway. Here's your diagnostic moment. Attempting to pass an orogastric tube. It stops at 10 to 12 centimeters, coiling in the proximal pouch. This is pathognomonic for EA. Leave that tube in place. You'll need it for your confirmatory X-ray. The radiographic findings tell you which type you're dealing with. Air in the GI tract means there's a distal fistula connecting the trachea to the lower esophagus. That's your type C. A gasless abdomen suggests isolated atresia without any fistula connection. Understanding vectoral screening is essential because 50 to 70% of these infants have associated anomalies. The acronym covers vertebral, anal, cardiac, tracheal, esophageal, renal, and limb defects. Cardiac anomalies occur in about 30% and may influence your surgical approach. The key insight is that EA and TEF rarely occurs in isolation. Your diagnostic workup needs to identify associated conditions that could impact surgical timing, anesthetic management, and long-term outcomes. Early echocardiography becomes particularly important since cardiac defects may require coordination with cardiology before esophageal repair. Once you've confirmed the diagnosis, your pre-surgical management focuses on preventing aspiration and minimizing complications from that fistula connection. The replogal tube becomes your most important tool. Position it carefully in the proximal pouch and connect it to low continuous suction at 5 to 10 centimeters of water. Here's why this matters. Without constant drainage, secretions accumulate and spill over into the airway, but the tube needs meticulous maintenance. Irrigate with 0.5 to 1 milliliters of saline every 1 to 2 hours to prevent plugging from thick secretions. Patient positioning serves dual purposes. Keep the head elevated 30 to 45 degrees to prevent reflux through a distal fistula. If you're dealing with isolated EA, position the infant on the right side to promote drainage from that blind upper pouch. Ventilation management requires careful consideration. Avoid CPAP and high positive inspiratory pressures because they force air through the fistula directly into the stomach. This creates a dangerous cycle. Gastric distension compresses the diaphragm, worsening respiratory function. If ventilation becomes necessary, use the lowest pressures possible or consider high-frequency oscillatory ventilation. When gastric distension becomes severe enough to compromise breathing, you may need emergent gastrostomy placement. The preoperative evaluation can't wait for convenience. Get an echocardiogram immediately. 30% of these infants have congenital heart disease that could influence your surgical approach. Renal ultrasound and vertebral X-rays complete the vectoral screening, but cardiac evaluation takes priority because it directly impacts anesthetic management. Understanding this pre-surgical phase prevents the complications that can derail an otherwise successful repair. Every intervention connects to the underlying pathophysiology. You're working around an abnormal connection between two systems that should be separate. The goal is reaching surgery with stable respiratory function and minimal aspiration risk. When you accomplish that, you've set the stage for successful surgical repair. The surgical approach varies dramatically based on anatomy, and understanding why each type requires different strategies helps you anticipate outcomes and complications. Type C repair represents the straightforward approach, since 85% of cases fall into this category. The surgeon uses a right thoracotomy to access both the fistula and the esophageal ends. The key steps include ligating that distal fistula first, then creating an end-to-end esophageal anastomosis. Success depends entirely on gap length and tissue quality. If the gap is too long, attempting to force the connection creates excessive tension that leads to dehiscence. The post-operative chest tube monitors for anastomotic leaks. Long gap EA presents an entirely different challenge. When the esophageal ends can't be brought together safely, you need patience and ingenuity. Initial gastrostomy placement provides feeding access while you work on gaining length. Growth induction techniques include daily stretching of the pouches or circular myotomies to lengthen the esophagus gradually. You're essentially coaxing the tissue to grow and stretch over 2 to 3 months. When growth techniques fail, esophageal replacement becomes necessary. Gastric pull-up involves mobilizing the stomach and bringing it up into the chest to replace the missing esophageal segment. Colonic interposition uses a segment of colon as a conduit. Both are major reconstructive procedures with their own complications, but they restore continuity when no other option exists. H-type fistulas offer the simplest surgical challenge. The cervical approach allows direct access to divide that abnormal connection between the trachea and esophagus. Since both structures remain intact, there's no need for complex reconstruction. Post-operative complications are minimal because you're not creating anastomoses under tension. The fundamental principle: match your surgical strategy to the anatomical reality. Don't force repairs that create excessive tension, and remember that sometimes the best approach is staged reconstruction rather than attempting everything in one operation. Post-operative care revolves around one critical principle: protecting that fresh anastomosis while it heals. Every intervention connects to this fundamental goal. Ventilation management requires extreme caution. Keep pressures low because excessive pressure can literally blow apart the anastomosis. The suture line is fragile for the first week, and high inspiratory pressures create stress that leads to dehiscence. Extubate as soon as it's safe to do so. The less positive pressure, the better. Here's a critical safety point: never pass suction catheters beyond the endotracheal tube tip. Hitting that fresh anastomosis with a suction catheter creates mechanical trauma that can cause immediate disruption. This isn't theoretical. It's a real risk that can turn a successful repair into a surgical emergency. Anastomosis protection means giving the tissue time to heal before challenging it. No oral or NG2 placement for 5 to 7 days. That suture line needs to develop tensile strength without mechanical stress. The chest tube stays in place until you're certain there's no leak because any anastomotic breakdown needs immediate drainage. The contrast study at 7 to 10 days serves as your green light for feeding. This isn't arbitrary timing. It takes about a week for initial healing to create a seal strong enough to handle luminal contents. Once that study shows integrity, you can cautiously begin feeds. Your feeding approach acknowledges the inherent problems these infants face. Start with human milk or elemental formula because the repaired esophagus has compromised motility. These babies have dysmotility and reflux as baseline conditions, not complications. Small, frequent feeds work better than large volumes that can overwhelm the damaged esophageal function. Anti-reflux positioning becomes essential because gastroesophageal reflux is almost universal after repair. The native esophagus lacks normal peristalsis, making reflux management a long-term challenge. Understanding these principles helps you anticipate problems and intervene appropriately. Every aspect of post-operative care protects that vulnerable anastomosis during its most critical healing period. EA&T if repair brings significant long-term challenges that extend far beyond the initial surgery. Understanding these complications helps you anticipate problems and counsel families appropriately. Early complications center around that vulnerable anastomosis. Anastomotic leaks occur in 15 to 20% of cases, usually detected through chest tube drainage or routine contrast studies. When leaks happen, you'll need NPO status and chest drainage until healing occurs. Most small leaks heal without reoperation, but they often lead to stricture formation later. Recurrent fistulas develop in 5 to 10%, typically from incomplete initial closure or excessive tension on the repair. These require surgical revision. Vocal cord paralysis affects 15% due to injury to the recurrent laryngeal nerve during thoracotomy. Speech therapy helps, but some children have permanent voice changes. The late complications create lifelong management issues. Anastomotic strictures develop in 30 to 40%. That's almost 1 in 3 patients. They present as feeding difficulties weeks to months after repair. The stricture forms because the anastomosis heals with scar tissue that contracts over time. Serial dilations usually work, but it requires patience and repeated procedures. Here's what's truly challenging. 75% develop dysmotility because the repaired esophagus never functions normally. The native peristalsis is permanently damaged. Gastroesophageal reflux affects 40 to 65% for the same reason. The esophagus can't clear acid effectively. Tracheomalacia occurs in 20 to 30% from in utero compression. These children have that characteristic barking cough and may need positive pressure support, or even surgical aortopexy for severe cases. Recurrent respiratory infections plague these children through early childhood because of chronic aspiration from reflux and dysmotility. The key insight? EA&TF repair saves lives, but it doesn't restore normal function. These children face ongoing feeding challenges, respiratory problems, and require long-term specialized care. Success isn't just about surgical technique. It's about managing a chronic condition with multiple system involvement. Understanding duodenal obstruction starts with grasping a fundamental embryologic concept that sets it apart from other intestinal atresias. During normal development, the duodenum begins as a solid cord of tissue that must hollow out through a process called recanalization between 8 and 10 weeks of gestation. When this process fails, you get different types of obstruction depending on how complete that failure was. Let's break down the 4 main intrinsic causes because each represents a different degree of developmental failure. Duodenal atresia represents complete failure. There's no lumen at all, creating total obstruction. Think of it as a completely blocked pipe. Duodenal stenosis occurs when recanalization happens, but incompletely, leaving you with a narrow opening that creates partial obstruction. It's like a pipe that's nearly pinched shut. Duodenal webs are intraluminal membranes that partially obstruct flow. Picture a curtain stretched across the duodenal lumen. Some contents can get through, but not easily. Finally, annular pancreas creates a different problem entirely. Here, pancreatic tissue wraps around and compresses the duodenum from the outside, like a belt that's too tight. The numbers tell an important story about frequency. Atresia dominates at 50%, followed by stenosis at 35%, then webs at 15%. This distribution reflects the spectrum from complete developmental failure to partial problems. Here's what makes duodenal obstruction particularly significant: the 30% association with Down syndrome. This isn't coincidental. It reflects the timing of duodenal development during a critical period of organogenesis when chromosomal abnormalities exert their effects. This association mandates chromosomal evaluation in any infant with duodenal obstruction. Some cases show familial clustering, suggesting genetic factors beyond chromosomal abnormalities influence duodenal development. Understanding these patterns helps you recognize when genetic counseling becomes important for families. The key insight is that duodenal obstruction represents a spectrum of developmental failures during a specific embryologic window, with predictable associations that guide your diagnostic approach. Recognizing duodenal obstruction requires understanding how the clinical presentation and imaging findings connect to the underlying pathophysiology. The prenatal clues often provide the first hints. Polyhydramnios occurs in 85% of cases because the fetus can't swallow and absorb amniotic fluid normally. There's nowhere for it to go past the obstruction. This creates excess fluid that obstetricians notice on routine ultrasounds. After birth, the classic presentation unfolds predictably. Bilious vomiting starts within 24 to 48 hours because the obstruction is almost always distal to the ampulla of Vater, where bile enters the duodenum. Here's what's different from more distal obstructions. You'll see minimal abdominal distension, and it's limited to the upper abdomen. Why? Only the stomach and proximal duodenum can fill with air and fluid. Everything beyond that remains collapsed. The double bubble sign on plain radiographs is pathognomonic for duodenal atresia. Picture two balloons side by side. One represents the dilated stomach, the other the distended proximal duodenum. This classic finding appears in 75 to 85% of cases. With complete obstruction, no gas passes distally, so you'll see nothing beyond those two bubbles. Halves where it gets tricky. Partial obstructions from webs or stenosis may show some distal gas, making the diagnosis less obvious. That's when upper GI contrast studies become essential. Complete obstruction shows contrast stopping abruptly at the obstruction site. Partial obstruction demonstrates delayed passage with significant proximal dilation. The windsock sign deserves special mention. When contrast outlines a duodenal web, it balloons downstream like a wind-filled sock. This pathognomonic finding helps distinguish webs from other causes. The key insight is that duodenal obstruction creates a unique pattern because only the most proximal structures can dilate. This limited involvement helps differentiate it from more distal obstructions that create widespread bowel dilation. Understanding this anatomical relationship makes the diagnosis clear when you see that characteristic double bubble with absent distal gas. Once you've diagnosed duodenal obstruction, your pre-aughers management addresses both the immediate physiologic derangements and the underlying associated conditions that make these cases complex. Start with the basics, NPO and gastric decompression to prevent further vomiting and aspiration. But here's what's crucial: fluid resuscitation with careful attention to electrolyte correction. These babies develop hypochloremic metabolic alkalosis from prolonged vomiting of gastric acid. You're not just replacing volume, you're correcting a specific acid-based disturbance that can complicate anesthesia and surgery. The genetic evaluation for Down syndrome isn't optional when you're dealing with duodenal obstruction. Remember that 30% association? It's high enough that chromosomal analysis becomes standard care. But here's what really matters for immediate management: the echocardiogram. 30% of these infants have congenital heart disease, and that cardiac status directly affects anesthetic risk and surgical approach. The surgical procedure centers on creating the widest possible connection around the obstruction. The duodenostomy, with its diamond-shaped anastomosis, isn't just surgical technique, it's about preventing future problems. A wide anastomosis reduces stricture risk and allows better flow around the repair. For annular pancreas, you never divide the pancreatic tissue. That invites pancreatic leaks and complications. Instead, you bypass around it, treating the pancreas like a permanent fixture you have to work around. Post-operatively, expect prolonged ileus lasting 7 to 14 days. This isn't a complication. It's the expected result of operating on chronically dilated bowel that's lost normal motility patterns. The dilated proximal duodenum needs time to shrink down and regain coordinated function. patience during feeding advancement prevents complications. Long-term outcomes tell the real story. For isolated duodenal atresia, survival approaches 95%. Excellent results! But overall prognosis depends heavily on those associated anomalies, particularly cardiac defects in Down syndrome patients. The duodenal repair itself rarely determines long-term outcome. Congenital atresias tell a different story than duodenal obstructions. While duodenal atresia stems from developmental failures during recanalization, congenital atresias result from catastrophic in utero vascular accidents. Think of them as bowel heart attacks that happen to the fetus. The classification system isn't just academic. It directly predicts surgical complexity and outcomes. Type 1, occurring in about 19% of cases, represents the mildest form, where only a membrane blocks the lumen, like a curtain drawn across a hallway. The mesentery stays intact, making repair straightforward. Type 2, the most common at 29%, involves a fibrous cord connecting the blind ends. Imagine a rope bridge between two cliffs. Again, the mesentery remains intact, preserving blood supply. Type 3A accounts for 36% and represents the turning point. Here, we see disconnected blind ends with that characteristic V-shaped mesenteric defect. This gap in the mesentery tells us significant vascular territory was lost during the initial insult. Type 3B, only 10% but critically important, creates the apple peel deformity. The distal small bowel coils around a single retrograde vessel, like peeling an apple in one continuous strip. This precarious blood supply makes these babies particularly vulnerable. Type 4, fortunately rare at 6%, shows multiple atresias appearing like a string of sausages. This suggests either multiple vascular catastrophes or one massive event affecting extensive bowel territory. Understanding this classification helps predict which babies will need simple repairs versus complex reconstructions, and more importantly, which ones face the highest risk of short bowel syndrome. The clinical presentation of congenital atresia differs significantly from duodenal obstruction patterns. While duodenal atresia typically presents immediately after birth, congenital atresia may have a more gradual onset as air progressively accumulates proximal to the obstruction site. The clinical manifestations follow a predictable sequence. Approximately 70% of infants fail to pass meconium within the expected timeframe, which should prompt immediate investigation. Bilious vomiting develops as the obstruction becomes functionally complete. Progressive abdominal distension follows a characteristic pattern. The more distal the atresia, the greater the number of bowel loops that become dilated proximal to the obstruction. Radiographic evaluation reveals multiple dilated bowel loops with air fluid levels visible on upright films. When the atresia involves proximal jejunum, the classic triple bubble sign appears, representing dilated stomach, duodenum, and proximal jejunal segments. However, the diagnostic gold standard remains the contrast enema, which demonstrates microcolon, the characteristically small, unused colon that results from lack of luminal contents passing through during fetal development. The contrast material cannot reflux proximally beyond the atretic segment, confirming the diagnosis. Surgical management requires careful consideration of both immediate repair and long-term functional outcomes. The massively dilated proximal bowel segment demonstrates poor motility and must be resected back to normal caliber intestine. The significant size discrepancy between normal proximal bowel and the small distal segment typically necessitates an end-to-oblique anastomosis to prevent anastomotic complications. Critical surgical decision-making involves preserving maximal bowel length while ensuring functional outcomes. Extensive resections or multiple atretic segments carry substantial risk for short bowel syndrome. Additionally, these patients face a 15% long-term risk of adhesive bowel obstruction, emphasizing the importance of meticulous surgical technique for optimal outcomes.